Hi, my name is Shayan Musa, and I'm a resident working with Dr. Jeff Elias at the University of Virginia. In this video, I'll briefly walk you through a magnetic resonance guided focused ultrasound thalamotomy. This procedure is incisionless, minimally invasive, and FDA approved for the unilateral treatment of severe, medication-refractory essential tremor and tremor-dominant Parkinson's disease. The focused ultrasound transducer, which is attached to an MRI table, has a hemispheric phased array configuration of 1024 individual acoustic elements. The transducer can be translated in 3 planes and tilted to optimize its acoustic focus. The patient must first undergo a full head shave. This is necessary in order to prevent the formation of microbubbles and subsequent scalp burns. Baseline tests are then performed, which include kinetic and postural tasks. For more objective measurements of tremor, an MRI-safe accelerometer can be attached to the hand that will be treated. A stereotactic frame is placed as low as possible near the orbital rim and parieto-occipital junction in order to maximize the skull surface area available for transcranial sonication. Once the patient is in the MRI room, a silicone membrane is affixed to the scalp and positioned low over the pins. The head frame is then secured to the MRI table, and the silicone membrane is attached to the focused ultrasound transducer. Chilled and degassed water is used as a coupling medium for ultrasound transduction and to cool the scalp. After manually aligning the transducer, the patient is positioned inside the bore of the magnet to its isocenter. Preoperatively obtained volumetric CT and MRI scans are fused and used for planning. No-pass regions like aerated sinuses and intracranial calcifications are marked so that ultrasound will not be delivered through these areas. Localizer MR images are then acquired either in all 3 planes in relation to the intercommissural line or as a 3D scan that is later reformatted in all 3 planes. These reference images are fused to the preoperative CT scan and higher resolution MRI. Stereotactic planning can now be performed. Our typical target for lesioning the ventral intermediate nucleus is planned at 25% of the intercommissural distance anterior to PC and 14 mm lateral to midline, with adjustments made laterally in the case of ventriculomegaly and in the dorsal dimension for cases of less efficient transcranial delivery. No-pass regions are also set around membrane folds. A final adjustment of the transducer is made so that the natural focus is positioned to precisely match the stereotactic target. The patient is then placed back into the magnet for the treatment phase. The treatment phase involves 3 stages of sonication: focus alignment with target peak voxel temperatures of 40 to 45 degrees Celsius, target verification at 46 to 55 degrees Celsius, and therapeutic ablation at 56 to 60 degrees Celsius. The amount of energy that should be prescribed for each sonication is dependent on the desired target temperature. Note that the natural focus of the transducer, individual paths of ultrasound energy, and power from each respective element can easily be visualized. Intracranial heating caused by each sonication is assessed using MR thermography. Once the heating pattern has been verified to the proper location and clinical target, the acoustic energy is increased to temperatures necessary for a therapeutic ablation. The temperature graph depicts the peak voxel temperature in red and its average temperature with the immediately adjacent voxels in green. The patient may be clinically assessed at any point during the procedure. The procedure is ended when a satisfactory result has been achieved. Post-operative motor assessments are performed, and in this case, we can see improvements in both intention and postural tremor of the right hand. This concludes our video overview of the focused ultrasound thalamotomy procedure. Thank you for watching.